Diabetic ketoacidosis is an emergency, and as it's an emergency, it is essential to assess airways, breathing, and circulation, and to treat dehydration/shock adequately, and to frequently reassess the child. So scrupulous attention should be paid to fluid, electrolyte, and insulin management, as this is essential. So in diabetic ketoacidosis, the principal cause of death is actually cerebral edema. Other complications include aspiration and cardiac arrhythmias. So many children without a prior diagnosis of diabetes will have diabetic ketoacidosis as the presenting illness. And children known to have diabetes may develop DKA as a result of intentional or inadvertent insulin emission, particularly when coupled with illness. So again, it is important to consider the possibility of DKA in any child with symptoms suggestive of diabetes. So symptoms include obviously polyuria, polydipsia, weight loss, vomiting and abdominal pain can also be a presenting complaint, particularly in very young children. And you might have the odor of ketones on the breath, which I think that it says to smell like pear drops. And you might have Kushmal breathing, so that's deep breathing. So to confirm a diagnosis of DKA, diabetic ketoacidosis, you have to think about what the components of DKA are. So diabetic ketoacidosis, so diabetic, so we're thinking about glucose. So we're going to measure the blood glucose. Ketoacidosis, keto, that's ketones. So we want to measure the ketones. And acidosis, so we want to measure the blood pH. So glucose will usually be over or equal to 11 millimoles per litre, and ketones would be over 3 millimoles per litre. So you have to check blood gases without delay. And so the pH, so if the pH is less than 7.3 or the bicarbonate is less than 18 millimoles per litre, then this would be suggestive, obviously, of acidosis. And if, in addition to that, there's ketosis, DKA is essentially confirmed. So you don't necessarily need a blood glucose in this, because exceptionally a patient with DKA may have a blood glucose of less than 11, usually as a consequence of belated administration of insulin in the hours immediately prior to presentation. So they administer it, but they had already got the symptoms of DKA. So if you have ketosis without acidosis, i.e. high ketones, but there's no significant acidosis, this still means that there might be inadequate insulin on board. So it is imperative to give additional insulin to produce resolution of the ketosis, or DKA may occur. You should advise the patient to follow 6-day rules. So that's modification of the amount of insulin you give. So check the blood glucose frequently, at least 4 times a day, 2 to 4 hourly if ketones are over 0.6 millimoles, and do this until improved, and continue insulin even if not eating. The child may need more or less depending on the illness. And they should drink plenty of fluid, and you should give an extra rapid acting insulin to correct hyperglycemia, and recheck glucose in 2 to 3 hours and give further correction dose if necessary. So if the patient is ketotic and the glucose is not high, advise use of a highly palatable food and drink, e.g. custard or normal squash, to elevate the glucose and give insulin appropriately. So you might have to refer if the child remains unwell. So I'm now going to do a summary of what we have essentially talked about. So repeating the same stuff. Okay. So in our history, we're looking for polyuria, we're looking for thirst, polydipsia. Well, that's what we just said. Weight loss, abdominal pain, nausea, vomiting, confusion, loss of consciousness. In our examination, we're looking for acidotic breathing. That's Kushmal breathing. We're looking for increased rest rate, increased heart rate, dehydration, reduced consciousness. We will do our AVPU score of that to check that. So for our investigations, we want to look at our glucose, and that would be over 11 millimoles usually, in millimoles per litre. We were looking for acidosis, so that's less than 7.3 pH. We're looking for ketones, and we'll look for those in our urinalysis, and there will probably be, ketones like +2 or so, or ketonemia plus over 3 millimoles per litre. So we've confirmed it. That's DKA. So our management overview. We've made our diagnosis. Now it's urgent. So we want to assess our dehydration. So in order to assess dehydration, some important ways of assessing dehydration as opposed to shock is that they could have sunken eyes. You want to do a skin pinch, 1 to 2 seconds to just check whether they are dehydrated. You're looking for lethargy, with shock instead, as opposed to dehydration, you would have cold peripheries and weak absent pulses. So you do need to be able to differentiate. So then you want to do some resuscitation. So you calculate the fluids, and you're going to give fluids over 48 hours. And you want to give insulin, but you want to start it 1 to 2 hours after starting fluids. Then you're going to do monitoring. And the most important thing is to treat the underlying cause. What is the underlying cause of the DKA? So, again, resuscitation, do your ABC. If in shock, give 20 milliliters per kg bolus of 0.9% saline as quickly as possible. Otherwise, 10 to 20 milliliters per kg of 0.9% saline over 1 to 2 hours. So you have to repeat until peripheral circulation is restored. Okay, so again, we want fluid replacement. And with our insulin, again, we don't want to start it immediately. And so you want to give hourly boluses or commence an infusion. never stop insulin. Insulin is essential to switch off ketogenesis. So what we're going to be monitoring, we have to look at our fluid balance chart. We have to look at our AVPU. We have to look at our heart rate, our respiratory rate, our blood pressure, and we have to look at our ketones and electrolytes if possible. So complications of DKA or the treatment, so aspiration, so insert NG tube if unconscious or vomiting, and consider ranitidine, hypovolemic shock. So you want to do a thorough hydration assessment and appropriate fluid resuscitation. Hypokalemia. So if potassium is unavailable, encourage potassium-rich foods, e.g. bananas. Cerebral edema. So you reduce the risk of this occurring by delaying starting insulin until fluid given for 1 to 2 hours and replacing fluid over 48 hours.